Hello, my name is Caitlin Connor, and today we're going to be discussing intraventricular hemorrhage, or IVH. At the conclusion of this course, the learner will be able to identify clinical manifestations and diagnostic findings of IVH, should be able to describe IVH and what the bedside nurse's role is in preventing the development of IVH, how to perform a proper hands-on assessment, and how nursing interventions impact the development of IVH. This presentation is geared towards current registered nurses who work in a level 3 or 4 neonatal ICU. However, it will be very beneficial for nursing students who are looking for a career in the neonatal ICU in the future. So some background on IVH. Intraventricular means within the ventricles, and since we are talking about it, it's the ventricles in the brain. And then hemorrhage is excessive bleeding. So essentially, intraventricular hemorrhage is excessive bleeding within the ventricles inside of the brain. This is a major neurological complication that primarily affects neonates, premature neonates. And IVH is diagnosed and then graded on a scale from 1 to 4. So a grade 1 bleed is bleeding near the ventricles within the brain. A grade 2 is bleeding in the ventricles. A grade 3 is enlargement of the ventricles from the excessive bleeding. And then a grade 4 is bleeding that extends out of the ventricles and into surrounding brain tissue. Signs and symptoms of IVH include apnea and bradycardia, pallor or cyanosis, weak suck, high-pitched crying, seizures, bulging fontanelles, which can indicate hydrocephalus, anemia or a sudden drop in the hematocrit, hypotension, acidosis, and a change in muscle tone or level of consciousness. Comorbidities for IVH include low birth weight, anything less than 1,500 grams, rapid volume expansion, and then prematurity is the most common comorbidity. Along with prematurity, there is increased incidence of IVH for patients who are intubated, are on any type of respiratory support, whose mother had prolonged premature rupture of the membrane prior to delivery, and then not fully understood, but there has been a link in mothers who conceived through IVF and having a premature delivery resulting in IVH. So the pathophysiology behind IVH, it's not fully understood, but there are some ideas that lead to why this occurs. So in a premature infant, the germinal matrix vasculature is very, very fragile, and this is just an inherent immaturity of the vasculature. There's not really much that can be done to speed up that maturity process. So that fragility causes those blood vessels to easily break, which leads to the hemorrhaging. There is disturbance in the cerebral blood flow. This can happen with fluctuations in the cerebral blood flow, such as hypoxia or acidosis. If there's high cerebral venous pressure, which can happen with a pneumothorax, or if the patient needs high ventilator settings. And then abnormal blood pressure. So this can be caused by like dehydration, sepsis, or just immaturity of the nervous system to regulate blood pressures. And then lastly, platelet or coagulopathy disorders such as thrombocytopenia or DIC can also cause IVH. So in order to diagnose IVH, the gold standard is going to be head ultrasound. This is typically done 7 to 14 days after delivery. If IVH is identified, they will grade it, and then they will also do a repeat head ultrasound at 36 to 40 weeks corrected. And this is to assess whether it's progression or regression of the IVH, and if there is any suspicion of periventricular leukomalacia or PVL. If the patient does have suspected PVL on a head ultrasound, they will go down for an MRI, which will give the confirmation diagnosis of PVL. PVL is just the softening of the white brain matter inside of the brain. Treatment options for a patient that has IVH is going to be just a management of the symptoms. There's not really any way to improve it, which is why prevention is key in IVH. So some differential diagnoses for IVH are going to be apnea of prematurity, which is when a neonate stops breathing for about 15 to 20 seconds, which subsequently causes bradycardia and a decrease in oxygen saturations. This can be managed with IV caffeine, and eventually the neonate will grow out of this, which is something that might not happen if the apnea is being caused by IVH. Another diagnosis is going to be hypoxic ischemic encephalopathy, or HIE, which is when there is limited oxygen or blood flow to the brain during birth, which can cause brain injury. One of the, negative impacts of this is that premature neonates are not able to be treated with induced hypothermia, which is something you would do if an older neonate ended up having a traumatic delivery and was suspected of having HIE. And then this also does produce the long-term complications. And then the last differential diagnosis is going to be blood loss. Anemia can be caused by pulmonary hemorrhage, spleen or liver rupture, other internal bleeding. So it might be hard to determine if that blood loss is from the IVH or if it's somewhere else in the body. So the long-term outcomes of IVH really depend on the grading. So if it's mild IVH, such as a grade 1 or 2, this could have minimal or no disabilities later on in life. So if it's severe intraventricular hemorrhage, which is a grade 3 or 4, you would most likely see some pretty detrimental effects, such as cerebral palsy is common, seizures, and then a need for trach respiratory support, G-tube for feedings, pulse ox monitoring, subsequent oxygen, and then you'd also be on multiple medications to help manage any seizures or spasticity that you might have. So some of the questions that I would anticipate to have from the audience are going to be like, what can you do to prevent IVH? You can do a few things, such as a golden hour admission, and then for the next 7 days you will limit all handling of the infant, so the neonate will not be picked up. We do not handle them, move them around, lift them up. We try to minimize any touching as much as we possibly can. Reducing stimulation, so keeping it very quiet, dark. We do not, again, let parents hold, minimizing any movements that we can so that we're not disrupting the balance of the blood flow into the brain. And then thermoregulation, making sure that they're not too hot, too cold, and everything just stays generally regulated. And then another question I would assume we might get is, how should I monitor for the development of IVH? Which is a really good question, because this is where a lot of very, very minute details might play in. So you want to measure FOCs, and any slight changes could signify hydrocephalus or IVH, as there is that increased fluid, whether it be CSF or blood in the brain. And then feeling for the fontanelles, or visibly just watching the fontanelles to make sure that they're not bulging. And then you'll want to closely monitor all the lab values, especially the CBC, which can signify the anemia that we'd be looking for, which can also signify bleeding. And then you want to keep a very detailed and accurate record of the apneas and bradycardias that the baby is experiencing. That way we can see if they need an adjustment to their caffeine, or if this is something that is correlating with other events, or is it just signifying that maybe they do have IVH and this is what's causing that. And that concludes my presentation on intraventricular hemorrhage, or IVH. My references are listed below. Thank you very much.